to complaints of headache of 9 days in duration. So 9 days prior to consult, our patient complained of left-sided headache, squeezing in pain with a severity score of 10/10, felt on the left frontal area, radiating to the left temple and to the back of the left ear. So associated symptoms included blurring of vision of the left eye, and at this point, patient was relieved by intake of paracetamol. So 8 days prior to consult, there was a recurrence of headache, of the severe headache, but now at 8/10, so a little bit decreased, associated still with blurring of vision and still relieved with paracetamol. Persistence of the blurring of vision as well as the headache during the interim. However, a few hours prior to admission, there was recurrence of 10/10 headache. Hence, the patient was prompted for consult and a barangay health center. And at the barangay health center, BP was taken and was at 210/110 mmHg. So then patient was assessed as having hypertensive urgency at that time and was given sublingual antihypertensives. Patient was then transferred to our institution for further management. So at the emergency department, IV paracetamol was given for the headache and the carbidipine drip to manage hypertension, and patient was then admitted for workup. So at this point, our patient was referred to IM neuro service with an initial diagnosis of hypertensive urgency and tension headache with plans for further workup. And no, on the day of the admission of our patient, there was still persistence of the left-sided headache and worsening of blurring of vision. So the patient was still continued on antihypertensive medications and analgesics and was requested with imaging and laboratories that will be discussed in a little while as management in the floors. So after 1 day of being admitted, patient was referred to our service as referred by neuro, and upon assessment or upon questioning our patient, she verbalized having previous episodes of severe left-sided headaches.
So let's stop that now. Based from the history, what do you think is lacking from the management?
I think they were lacking on the fact that they didn't pay much attention on the blurring of vision. They just stuck with what was evident, which was the hypertension and the headache, but the progressing blurring of vision was neglected over the past few days of the symptomatology.
Yeah, so this is a pointer especially to our interns here. No, not all of you naman will go to ophthalmology, but this patient has been experiencing headache and blurring of vision for almost 1 week, and she sought consult at a health center. No, so hindi natin alam if that is equipped with a general practitioner. She sought consult at our ER, seen by residents. She was admitted, no, under internal medicine and neurology. Take note, without the detail here in the history, this is a private patient. So no health, no HMO, no HMOs. No. PhilHealth lang ang capacity ng patient to pay. So, ayun. Sige, let's proceed.
Okay.
I pointed that out because later on, that is significant to the management and the course.
Okay, so continuing on, so imaging and laboratories were requested, such as brain CT without contrast, and which revealed unremarkable, as well as a chest X-ray, which was normal. And upon doing laboratories, it was found that there were certain abnormalities in the hemoglobin, MCV, MCH, as well as the computation of the Menser index, which led to the internal medicine diagnosing her patient at this time with microcytic hypochromic anemia from iron deficiency, which they assume could be caused by abnormal uterine bleeding. This is because our patient has been complaining of bleeding a month prior, and hence they thought or they considered that the abnormalities in blood might have been caused by the bleeding. Okay, continuing on. For the past medical history, our patient allegedly Says that she has no history of hypertension, diabetes, and migraines. Patient has no allergies. She is a spectacle user and is hyperopic upon probing. No surgeries and no trauma that has happened, and no ocular medications being instilled. For my family medical history, there's history of hypertension and myocardial infarction. Her personal social history, it is unremarkable. So at this point, physical examination showed that the VA is at J4 on the right and counting fingers on the left. Just this is because we were doing it in the wards, so it's and because we can only do it until J10. So after that, it was already counting fingers. Refraction was not done. Lids not unremarkable. The conjunctiva was non-hyperemic, and the rest was unremarkable except for a tear breakup time of less than 10. So upon grossly examining our patient, I showed that the anterior chambers were shallow, and the pupils at this point were found to be mid-dilated. Okay, so because of our initial findings, we requested the patient to be brought to the eye center for further evaluation. So at this point, these physical examination findings have been done in the eye center. So the visual acuity is 2200 on the left and still 2025 on the right. Refraction was not done, lids not unremarkable. The conjunctiva was non-hyperemic. The cornea was seen to be slightly hazy on the left with microcysts and pigments suspended in the anterior chamber. So gonioscopy findings revealed the angles to be closed and the IOP at 60 on the left eye, while the right remained unremarkable. So for the pupils, it was still mid-dilated and the iris showed iris bombay. Um, the iris was also pigmented with no neovascularization and the lens showed glaucom flecken. So this is a representation of the fundus of our patient. So for a right eye, um, it was taken with a fair photograph quality. The optic disc appears yellow-orange with distinct disc margins. The disc and cup well defined. Estimated vertical cup to disc ratio is approximately 0.7 and horizontal cup to disc ratio approximately 0.7 as well. However, there was noted thin superior and inferior neoretinal rim and a blunted RNFL reflex. For the left eye, fair photograph quality with an optic disc appearing to be a bit yellow orange, pink to yellow orange, and a distinct disc margin as well. The disc and cup are still round, however, with estimated vertical cup to disc ratio of also 0.7 and a horizontal cup to disc ratio of 0.7. There's also noted thin superior and inferior neoretinal rim and a blunted RNFL reflex. So, for salient features, we have a 54-year-old female with no known or allegedly no known comorbidities who presented with recurrent severe left-sided headaches of 9 days. The headache is described as squeezing in character with intensity reaching up to 10 out of 10. The pain is localized to the left frontal region and radiates to the left temple and postauricular area. There's also noted progressive blurring of vision. Um, and there And despite attempts of blood pressure control, the headaches persisted. On examination, the VA was 20 over 200 with anterior chambers shallow, mid-dilated, and with noted significant findings on slit lap examination. So with this, our primary impression is acute angle closure attack of the left eye, dry eye syndrome of both eyes, hypertensive urgency, and microcytic hypochromic anemia.
So, Joe, at this time, what is missing in your physical examination, especially the objective? Did you get, did you test the pressure?
Yes, di lang naka-state talk. But earlier I stated that the pressure was at 60 mmHg for the left.
60.
Yes,
Okay.
60.
So what's your impression?
My impression, doc, is acute angle closure attack of the left eye with dry eye syndrome of both hypertensive urgency and microcytic hypochromic anemia.
Sige. Proceed ka.
So for a differential diagnosis, we're considering three main possibilities, which is primary angle closure attack, secondary angle closure attack, and hypertensive crisis with ocular involvement. So, for primary angle closure attack, which is we believe the most likely diagnosis, the patient presented with markedly elevated intraocular pressure of 60 with significant decrease in visual acuity. The pupil was also mid-dilated and anterior chamber was shallow. There was clear evidence of pupillary block demonstrated by the presence of iris bombae and corneal microcystic edema, and the presence of glaucom flecken supports prior episodes of intraocular pressure elevation. So imaging that we will be discussing later will further support these findings. Secondary angle closure attack was considered, but a bit less likely because while secondary causes are present with very high intraocular pressure and decreased vision, a patient had no signs of iris or angle neovascularization, no intraocular inflammation, and no evidence of lens subluxation or intumescent cataract. But this could still be doubtful because when we examine the patient, the corneas were hazy and will not be able to fully know if the cataracts had any if the patient had any cataracts at this point. Um, Additionally, the presence of iris bombae with pigmented iris favors a pupillary block mechanism rather than a secondary inflammatory or neovascular etiology. So our last differential is the hypertensive crisis with ocular involvement. This was considered by other departments as well, but although the patient had headache and a history of blood pressure elevation, hypertensive crises do not elevate intraocular pressures to a level as high as 60. Furthermore, hypertensive crises do not typically cause mid-dilated pupils or iris bombae. Fundoscopic examination also did not show any signs of hypertensive retinopathy, and the degree of visual acuity loss was disproportionate to the blood pressure findings. Taken altogether, the clinical presentation and examination findings are most consistent with primary angle closure attack. So with that, um, I would like to discuss the imaging findings that can further support our our diagnosis for our patient. So in front of you is the ONH and RNF LOU analysis, optic disc cube 200 by 200. So looking at this, we can see that it shows poor signal strength. Optic nerve head cupping is at zero point 0.7 with shallow cup volumes. Poor RNFL thickness and RNFL symmetry are noted. There was also noted superior and inferior RNFL thinning and marginally thin temporal RNFL for both eyes, and the isn't rule is no longer observed. So with this, tomography studies would show evidence for advanced glaucomatous optic neuropathy in both eyes. So upon getting the angle analysis and the anterior chamber analysis of the right eye, we were able to see that the anterior chamber angles appear to be open. The with deep iris insertion and approximately 22 degrees angular width and a flat peripheral iris. The central corneal thickness is at 516 microns. So this one for the left eye, so it shows that the anterior segment, thus the left eye, shows severely shallow anterior chamber with elevated lens vault value and thickened cornea, probably due to the edema. The Schaefer grade of our patient is 0, which means all angles are closed, and the right eye shows, earlier that we discussed the right eye, and it shows the left eye shows moderate lens vaulting and convex iris veins. So this our final diagnosis is acute primary angle closure attack of the left eye, hypertensive urgency, dry eye syndrome, both eyes, and microcytic hyperchromic anemia. So for discussion, glaucoma is the leading cause of irreversible visual impairment and blindness worldwide. A group of optic neuropathies characterized by selective and progressive loss of RGCs and their axons. It presents as thinning and loss of neoretinal rim and RNFL with corresponding visual field loss. It is estimated that in Asia, it will contain the highest absolute numbers of primary glaucoma in 2040, 18.8 million of primary open angle and 9 million primary angle closure glaucoma. So here we can see a diagram that illustrates the progression of glaucoma and explains why it is often asymptomatic in its early stages. So looking on the left side, we see that glaucoma begins with the retinal ganglion cells death and axonal loss, but these changes are initially undetectable, so patients at this point would have no symptoms. However, as the disease progresses, structural damage becomes more detectable. RNFL thinning can be seen on OCT even while the patient remains asymptomatic. Early functional changes may be detected within short wavelength automated perimetry before standard visual field testing. On the right side, you can see here functional impairment becomes evident. Standard automated perimetry shows visual field defects which progress from moderate to severe and can eventually lead to blindness. So for the pathophysiology of glaucoma, the apposition of the iris to the trabecular meshwork is as a result of abnormal relationships of the anterior segment structures. So to discuss appositional versus synochial closure, appositional closure, there's no synechiae between the iris and corneal endothelium, therefore, the angle can still be opened. However, in synochial closure, the angles can no longer be opened. So as for the anatomic levels, there are the causes of angle closure. We have four. We have first the iris pupillary block. Second, we have the ciliary body due to a plateau iris. The next is due to the lens, which would be phacomorphic glaucoma. And last would be due to posterior of the lens showing malignant glaucoma and aqueous misdirection. These are just listed signs and symptoms to watch out for of angle closure glaucoma. And these are the symptoms. Best for us to know because not all patients would present the same way. As for the management, it is important for us to break the attack and by treating the mechanism. So these are often the management that we give to our patients. First is IV oral acetazolamide or IV oral osmotic agents. The second is beta blockers. Third is alpha agonists, steroids, pilocarpine, and corneal indentation using goniolens. This is another management that we can do, laser iridotomy. So these are given to patients who have documented appositional or near appositional angle closure, presence of PAS or peripheral anterior synechiae, a history of previous angle closure attack, a significant risk for angle closure, a strong family history of angle closure glaucoma, a need for repeated pharmacologic dilation, poor access of ophthalmic care, and patients who cannot be relied upon to recognize symptoms of an acute attack. So this is just an additional follow-up with our patient. During the admission at around on the day that we've discovered that there is an acute angle closure attack, the patient was started on brimonidine timolol, Combigan, prednisolone acetate, Predforte, acetazolamide, as well as K-Lite. On the following day, upon rounds with our patient, our patient already denies headache nor eye pain with improvement of blurring of vision. The table on the right shows our findings during that rounds, and we were able to see that the visual acuity is now at J4. Um, there's also noted uh, no more mid dilation of the pupils at 3 to 4 millimeters, equally reactive to light, and the corneas here it seemed a little bit clear, but this is grossly found. The IOP, importantly, is already at 10 from 60 during this follow-up, and the anterior chambers still were shallow. So this is actually our patient today when we saw our patient in the eye center. So today, our patient, prior to this, the patient coming today, the patient already had an LI of the left eye as outpatient. And today, the patient had an LI of the right eye. And this is the findings of the eye today, wherein we were able to see the presence of vitreous fluid in front of the anterior chamber. And then this is a video of what we were able to see as well. Okay.
So before we go further for the report of Rich, do you have any questions from the consultants? What do you think is unusual in this case, Joe?
I think what's unusual in this case uh, is how it has already been happening for a long time, and only now did she present, or at least now only we found out that all her problems with the headache was actually attributed to glaucoma, acute an angle closure glaucoma. And also, I think what's different is also this presentation of the vitreous fluid found in the anterior chamber after the attack.
Anyone else?
So the on admission in the ER, the pupils weren't checked,
It was bit dilated.
mid-dilated, and that's it. Wala silang ginawa. Ano bang akala nila?
Actually, that's our issue nga, Doc. The patient was admitted under IM and referred to neuro without even referral to OFTA at the ER level. So the
One of the
patient,
most inconsequential concerns nire-refer nila sa OPTA, tapos ito hindi nila na-refer.
yes, Doc.
So,
And yun na nga, the problem, actually the patient was referred to me at the end. So 100,000 yung ginastos ng pasyente. All can be avoided by uh, acetazolamide as
so what
outpatient.
was their differential with the mid-dilated pupil?
And they didn't
Hindi nila in-assess.
assess the mid-dilated. Okay, they zeroed into the
Headache.
headache.
And the
Reactive.
BP.
The,
So reactive on ano on record yung pupil niya
sa ibang service.
o sa ibang
As
service?
the one who initially saw the patient at the
Oo.
floors. Actually, I was also wondering if it was an RAPD kasi the pupil was reactive pa rin eh. Wasn't the usual na mga block na nakikita ako sa ER before. So I was still asking the first consultant na ni-referent kung baka optic neuritis siya versus angle closure attack.
Pero
Kasi the eye was
mid-dilated.
red as well.
Mid-dilated.
Mid-dilated and shallow. Though.
Anyway,
And also, what is unusual is, remember, most of your acute angle closure would have a lens component, or parang a cataractus lens. This is a clear lens. And if you notice, there's also actually there's phacodonesis and iridodonesis as well. So we don't know if the phacodonesis is brought about by the attack or the attack caused the phacodonesis. Diba? Because a very mobile lens can also block. Diba? But a very high pressure with very pushed forward lens can also break the zonules, weaken the zonules.
okay. All right,
And
sige.
Doc, have you just a question to the consultants, have you encountered this kind of vitreous in the anterior chamber after that?
Was
Because
it there? It was only there when? After LI na o dati pa yan nandiyan?
dati pa, Doc. And if you can see, well, the vit is really coming from the pupil, not the iris naman.
Did you dilate?
Hindi pa ako nag-dilate, Doc.
Dilate nyo yan, may zonulisis yan for
Yun
sure.
na nga eh.
So for sure may zonulisis yan na lumabas ang vit. How old's the patient?
54.
54. Okay. For sure may zonulisis yan. I don't know if the zonulisis is a parang de novo na talagang zonulisis yung condition niya na nag-cause ng vit to move forward and maybe some block, or the zonulisis is from the glaucoma na I don't know which came first, no.
Yes.
But vitreous like this in an intact lens will only come from zonular spaces. So I would suggest kung safe na siyang i-dilate, dilate niya para makita niya saan nanggagaling yung fit.
Pero ayun, again, if yung mga interns natin maging ER doctor, IM, or neurologist, please do the differentials very well and the referrals very well. Okay?
Go ahead.
Right. So moving forward to the discussion, I have here a journal which looks into the association of antihypertensive medications with RNFL and GCIPL thickness. So basically, they started the study to evaluate the association of these two factors, especially in a non-glaucomatous, multi-ethnic Asian population. So this followed a population-based cross-sectional study design that involves a total of 9,144 eyes for RNFL analysis and 8,549 eyes for GC-IPL analysis, with a main outcome measure of average and sectoral RNFL and GC-IPL thickness. So again, the researchers see glaucoma and hypertension to be chronic age-related conditions associated with increased patient morbidity and healthcare burden. So there is a complex relationship between BP and glaucoma, with multiple interacting factors modifying both IOP and ocular perfusion. We also see that there tends to be a diurnal variation for IOP as well as BP that could result in periods of decreased ocular perfusion in certain individuals, whether they be in physiologic conditions or on treatment conditions. So the study took data from the Singapore Epidemiology of Eye Diseases study, collecting data from adults aged 40 or older between three major ethnicities, which is the Chinese, Indians, and Malays. So basically, they did regression models to investigate the association of antihypertensive medications with OCT measurements. And exclusion criteria included patients without or with missing OCT data, OCT segmentation errors, poor scan qualities, or eyes with active glaucoma or ocular hypertension on IOP lowering medications. They also excluded other patients with neurodegenerative diseases or macular pathologies. So antihypertensives were recorded on the basis of whether no medications were taken, or one medication were taken, or two or more medications were being taken. And medications were also being classified as to what class of antihypertensives were being given. So again, as mentioned, they utilized linear regression models, comparing the association of antihypertensives with the RNFL and GCIPL, and further stratifying it based on the class of medication and the number of the medications that the patient was taking. They also adjusted for other potential confounders such as age, gender, ethnicity, mean arterial pressure, the presence of DM, BMI, or even intraocular pressure. And so they collected a total of 4,699 participants with a mean age of 58 years, most of which were female. As one might expect, participants taking two or more types of medication were significantly older at a mean of 64 years, compared to those with only one or no antihypertensives. And for the results, among the included participants, they found that 64.8% were not taking any form of antihypertensives, making up the majority of their sample. Meanwhile, those on two or more medications were at 16.6%. Of the persons on antihypertensives, they found calcium channel blockers to be the most common, with 16.5% of participants taking this, followed by beta blockers, ACE inhibitors, angiotensin receptor blockers, and diuretics at 6%. Participants on more than two medications were usually on a combination of calcium channel blockers and beta blockers. And they also noted that the average peripapillary RNFL thickness was at around 92 micrometers, and the average GC-IPL thickness at around 80 micrometers. So generally within the normal range. So they subjected the data to linear regression, and we find that the use of any hypertensive medication was actually significantly associated with a thinner average RNFL, with a beta of minus 0.83. This is taking into account all of the identified factors and confounders earlier, hence the model 2. Consistently, they also found that a greater number of antihypertensive medications were associated with thinner RNFL thickness compared to those with fewer or no medications. And the analysis moreover finds that the use of ACE inhibitors and diuretics were more significantly associated with thinner RNFLs compared to other types of medications. And similarly, compared to your GCIPL, they noted similar associations with, again, antihypertensive medications associated with a lower average macular GC-IPL thickness. So consistently, the greater number of antihypertensive medications were associated with thinner thickness. And they also found ACE-ICE to be significantly associated with a thinner GC-IPL thickness. So they actually found these trends to be consistent when comparing the effect of specific antihypertensives on both the inferior and superior hemispheres. So to basically run into the details they found, they demonstrate the association of, again, antihypertensives with specifically the use of ACE-ICE and diuretics on the RNFL and GCIPL thickness after adjusting for their BP and intraocular pressure. On prior studies, they actually found that lower ocular perfusion pressure may be associated with a higher rate of progression. And studies on ambulatory BP measurements, for instance, do conclude that the duration of nocturnal decreases in BP, which is what they call nocturnal dippers, tend to have the strongest association with progressive glaucomatous vision loss. So this was in agreement with a meta-analysis that reported that a nocturnal reduction in BP of more than 10% was associated with glaucoma progression. So it is then possible for ACE-ICE and diuretics to also exert different effects on the ocular microvasculature, whether structurally or functionally, in terms of diurnal BP regulation. So there's this study called the Hypertension Objective Treatment Based on Measurement by Electrical Devices of BP study, which found that monotherapy with ARBs or ACE-ICE resulted in greater morning BP variability in comparison with other medications such as calcium channel blockers. Certain antihypertensives have also been found to alter neuronal health in the eye, independent of BP and intraocular pressure. Although this is largely based on preclinical models of neurodegenerative diseases. Research on ACE inhibitors, for instance, have found that with angiotensin converting enzyme being responsible for cleaving amyloid beta protein in vivo, there may be a possibility for prolonged ACE-ICE to increase beta protein deposition in the retina, inducing RGC death. So just to basically conclude, certain types of antihypertensives must be carefully considered when we treat and see patients, especially with those with vulnerable optic nerves. So it may be easy to neglect the systemic side of our patients. However, we need to supplement our findings with complete and relevant clinical history beyond just the ocular side, and pay close attention to a patient's comorbidities and risk factors. In the case of the patient Joe presented, the patient was eventually discharged on a combination of an ARB and calcium channel blocker. So I guess in terms of, in relation to the study, we wouldn't have to worry so much about the effect of the patient's antihypertensives. So that more or less concludes John and I's presentation.
Any questions from the consultants or comments? Joe, true or false? Hypertension is good for glaucoma.
False.
True or false na?
False na lang, false.
As
No,
false.
it's not.
Siyempre.
Isip din ako eh.
As much as as much as possible, while the presentation of Rich tells us that hypertension is antihypertensive medications can progress, can make the glaucoma progress. Syempre, our target pa rin is just the right amount of blood pressure. So you don't incite naman hypertension to a glaucoma patient. Any other questions or comments? So again, to our interns and even to our residents, no, whatever you do to your patients, sometimes, especially in our healthcare setting, one hospitalization, one surgery can be the difference between a low middle class to poverty. No? So be prudent with your requests, whether it's an OCT, uh, a photo, an FA, no? Or a CT scan. In this case, may CT scan pa, no? Just to to look for a problem
May
na
nakita ba sa CT scan?
wala
Wala
daw.
po. Unremarkable.
Sinusitis.
This is how dependable our ER is. Anyway, sige. I think as it's easy for us to say, no, because we're all at least in the field, but I think this goes to our colleagues who are not from ophthalmology na hindi. Kung headache nga, palagi kayo nagre-refer na non-specific headache, nagre-refer sa opta. Ito pang left-sided periorbital headache na hindi nire-refer sa opta. So, I think you just have to know what the differentials are for a headache in order for you to be able to manage the patient as quickly and as efficiently and as cheaply as possible. Never mind the money. In this case, paano kung naging irreversible yung visual loss nito? 'Di ba? Secondary na yung finances dyan, but the more important thing is if you had caused irreversible visual loss on this patient, I don't know how that can be defensible. So let's just be careful out there. So thank you very much.
Thank you.
Thank you, Doc.
Thank you, Joe. And thank you, Rich. Thank you, everyone, to all consultants for attending. Please answer the attendance sheet.
Just announcement lang. Next week, maraming residents ang wala. So, let's just be a little bit more patient. No? 3 of our residents will be away from when to when? Thursday, Sunday,
4 to 8 for the app.
Wednesday to Sunday for the APAO. They all have posters to present. So congratulations to them as well. No? So we'll have 4 residents left. So we ask for your understanding. No? Okay. Thank you very much.
Doc, reminders to all service head for the board exam questions po.
Board exam questions, please send na.
Thank you.
Thank you, everyone.